Welcome to the Talking Ketamine podcast, the show where we explore the science behind this fascinating molecule. This is episode 40, Ketamine for Complex Regional Pain Syndrome.
Thanks for joining us. Today, we're moving way beyond ketamine's use in depression or anesthesia. We're looking at its powerful role in fighting one of the most severe types of chronic pain imaginable.
That's right. And we're going to be looking at what happens when the pain when it refuses to stop.
Refractory pain.
Exactly. We're focusing on this really intense case report about a 15-year-old athlete. She had a simple hand fracture, had surgery, and then developed this agonizing, persistent condition called complex regional pain syndrome, or CRPS.
And the key here is that the fracture healed perfectly. But the pain just exploded. It became this life-altering, constant thing that was totally out of proportion to the actual injury.
So for our analysis today, we want to unpack the very specific combined treatment they used to finally break that pain cycle.
And we really want to isolate the role ketamine played. I mean, how did it work to achieve what the paper calls central desensitization in a pain system that had just gone completely haywire?
Okay, so let's start with the villain of the story here. For anyone listening, when you hear chronic pain, you might think of, a nagging injury. How is CRPS on a whole different level?
It's a completely different beast. It's often ranked as one of the most painful conditions a person can experience. The real difference is that the pain is just. It's wildly disproportionate.
Disproportionate to the original injury.
Exactly. The body's tissue heals, but the nervous system, for some reason, fails to get the message. It stays on high alert, creating this pathological pain loop that just feeds on itself.
So the bone has healed, the cut is closed, but the brain is still screaming in agony.
That's a perfect way to put it. In this girl's case, she had this intense burning pain. She rated it a 7 out of 10, and that was just at rest.
Wow.
Her hand was swollen, a different temperature from the other one, and she was guarding it constantly because of this extreme hypersensitivity.
And that hypersensitivity has a specific name, right? It's a key feature of CRPS.
It does. It's called allodynia. And for anyone not familiar with the term, it is. It's a terrifying concept. It's when you feel severe pain from something that should never, ever hurt.
Like what?
Like the brush of a shirt sleeve, a light breeze. For this patient, she couldn't tolerate anything touching that hand because her brain was interpreting that normal, gentle signal as just excruciating.
It's so hard to even imagine that kind of sensory distortion. The case report actually describes her pain as, and this is a quote, like someone was taking a saw and chopping her fingers off one by one.
Chilling, isn't it?
It is.
No.
So why? Why does the nervous system fail so catastrophically? The x-ray showed the fracture was healed. Why was her brain still creating that level of pain 5 months later?
So this is where we get into the core mechanism.
Yeah.
The research points to something called central sensitization. Some people call it the wind-up phenomenon. Yeah. The best analogy is to think of your central nervous system, your brain, and spinal cord as having a volume knob for pain.
Okay.
When you get a bad injury, the system cranks that volume knob way up to an 11. And that makes sense, right? It's a protective mechanism. It's screaming, hey, protect this area.
But with CRPS, the knob gets stuck.
It gets stuck.
Yeah.
Even after the original injury signal is gone, that volume knob is jammed on maximum. So now a normal, non-painful signal, like a gentle tap that should register as a 2,
Is being interpreted as a 10.
as a terrifying, unbearable 10. The central computer has been rewired incorrectly.
So if the problem is basically moved upstream from the hand into the central processing unit of the brain and spinal cord, that must be why the first treatments didn't work.
You've hit it exactly.
Yeah.
You can try to treat the hand, but if the central computer is convinced it's under catastrophic attack, the pain is just.
Yeah.
It's embedded. That's why things like occupational therapy and NSAIDs failed her. The problem needed a different kind of attack.
So after 5 months, she was admitted to the hospital for this refractory pain. And it sounds like the specialists realized they needed a strategy that hit the problem from all sides, from the hand all the way up to the brain.
Yes, it was a really intelligent, multimodal approach. They knew no single drug was going to fix this. They had to target 3 different pathways at the same time.
Okay, what were they?
Well, first, they started her on Gabapentin.
Which is for, what, general nerve pain?
Pretty much. Think of it as just trying to turn down the overall static in the nervous system, a sort of general sedative for overexcited nerves.
Okay, so that's component 1, calming the general storm. What was 2?
Component 2 was regional, a continuous supraclavicular nerve block.
So numbing the actual arm.
Exactly. They place a tiny flexible catheter near the big bundle of nerves that goes to the arm, the brachial plexus, and just continuously dripped in a local anesthetic.
So it's like temporarily cutting the phone line from the hand to the brain.
That's the perfect analogy. It silenced all that incoming peripheral noise.
Okay, wait a second. So, if the nerve block is already stopping the pain signal from the hand, and the gabapentin is calming everything else down, what was the ketamine actually doing? Why did they also need a continuous ketamine infusion?
This is the most important part of the whole strategy. The ketamine wasn't for the hand. It was for the brain.
To fix the central problem.
Precisely. While the nerve block was handling the hardware, the ketamine was performing the essential software reboot on the central nervous system that was stuck in that horrible loop.
And how does it do that reboot? What's the mechanism?
So ketamine works on something called the NMDA receptor. For our purposes, you can think of that NMDA receptor as the main ignition switch that powers the entire central sensitization system.
Okay, so it's not the volume knob itself, but it's the master switch that turns the whole pain amplifier on in the first place.
You've got it. In CRPS, that ignition switch is stuck in the on position. Ketamine, as an NMDA antagonist, comes in and physically blocks that switch. It forces it into the RFF position.
It breaks the circuit.
It breaks the circuit. It interrupts that wind-up cycle, which finally gives the whole system a chance to rest and, well, to reset itself back to normal.
And that pain-free window is everything, because then she could actually start physiotherapy, right? To start moving again.
Absolutely essential. You have to break the pain cycle to enable movement, and that movement is what ultimately leads to long-term recovery.
So the big question, this all sounds brilliant in theory, but did it work? Was the result as dramatic as the condition itself?
It was. I mean, the word they use is dramatic, and it's accurate. The change was incredibly fast.
Really? How fast?
Within 24 hours of starting this triple therapy, her pain dropped from that 7 out of 10 down to a 2 out of 10.
In one day?
One day. And by 48 hours, her pain at rest was a 0.
Wow. And the allodynia, that sensitivity to touch?
Gone. It completely resolved. Her hand became warm, the swelling went down. She was able to start physiotherapy, actually using her hand again on the 4th day she was in the hospital.
That's a complete reversal of these severe symptoms in just a couple of days.
It's an amazing outcome. And it held. They discharged her on day 5 with a little pump that continued the nerve block at home. 9 days later, they took the catheter out.
And the follow-up?
The follow-up is the best part. At 6 weeks, she had made a full return to all her activities. She was back to competitive sports. The pain was gone, and it stayed gone.
That's just incredible. It's such a clear demonstration of how ketamine, when it's used so intelligently as part of a bigger plan, can do something truly unique. It wasn't just a painkiller here. It was a system reset button.
Exactly. This integrated approach, combining the central desensitization from the ketamine with the peripheral block. It's a fantastic example of its versatility.
It really is.
And it makes you think about the broader picture, doesn't it? It suggests that for certain conditions that are defined by the brain basically learning a faulty pattern, we need tools that can interrupt or even erase that bad learning.
Which makes you wonder, how many other chronic, so-called untreatable neurological problems are really just a stuck switch in the brain waiting for the right key to come along and turn it off?
A question that is absolutely worth exploring. The potential for targeting that NMDA receptor is, well, it's one of the most exciting fields in medicine today.
We hope this look at complex pain management has helped you understand another side of this fascinating molecule. Thanks for joining us. Until next time, keep exploring.